welcome to my Surrogacy Options podcast. And today, very pleased to welcome John Hesla from Oregon Reproductive Medicine in the US. John, welcome.
Thank you very much.
So perhaps if you could give listeners a bit of an overview of ORM and the services that you provide.
Our clinic is now celebrating its 30th anniversary. We have offices in Portland as well as in the Metro Seattle area. We just opened an office in Bellevue, Washington earlier this year. So we help people from the Pacific Northwest, but importantly, we also help many international patients. In fact, about 30% of all of the patients that we care for come from overseas. And the primary reason that international patients come to our clinic is because of the success rates that we've achieved through in vitro fertilization and the specialty services that we provide, including egg donation, surrogacy, and genetic screening of embryos.
And so what 30 years is a long time, as a whole career really. What attracted you to fertility medicine?
I attended university at Harvard, and during the summers I had off, I worked in a research laboratory here in Oregon that focuses on reproductive biology. So it was at the age of 17, I was doing surgery on monkeys as part of but so I was very interested in endocrinology and in reproduction as an academic exercise. But more importantly, when I went into medical school and did my training, I really enjoyed obstetrics and gynecology. I enjoyed the process of helping people have babies, have children. And I thought that reproductive medicine would be a great fit for me because it combines a lot of my interests, including fertility, endocrinology, surgery, psychology, and it's just been a wonderful career. I started my training in obstetrics and gynecology at UCLA during the first year that a baby was born in the United States through IVF, which was in 1982. So I've seen many, many changes over the past 35 years. And I'm excited to see what the changes will be over the next 35 years.
Well, perhaps we'll come on to sort of the future of fertility medicine in a moment. You mentioned that at ORM you've got an egg donor program. Could you just give an overview of the, if you like, the medical aspects of surrogacy?
Well, surrogacy involves having a woman help a patient, either a couple or a single individual, have a child. And through that process, which does involve in vitro fertilization, the woman who provides the egg could either be the intended mother of the child or it could be an egg donor. And many people do need the help of an egg donor, including same-sex male couples or single men. But also there are many women that we help who have problems with their egg quality, or they don't have any eggs at all and they need the help of an egg donor to help them have a child. So our clinic does have an in-house egg donor program. It's like an agency, but it's part of our clinic, where we recruit women from our region in the United States as well as in more distant regions of the United States to apply directly to our clinic to donate through our centers in Portland and in Seattle. The egg donors undergo a very vigorous screening process. There's many steps involved in screening the egg donor to make sure she's of optimal candidacy. We start by having the donor complete a medical questionnaire, which is very detailed. It provides information about her medical background, as well as the health background of 3 generations of her family. So in doing so, we're looking for any diseases that may have a genetic basis, a familial basis, so that we can determine if she's appropriate, and if she is appropriate, what potential risks may be for the future child in inheriting a disease that may have a genetic basis. The donor is interviewed by one of our genetic counselors. Our clinic does have 4 genetic counselors on staff who will do one-on-one interviews with all donor applicants to assess for any genetic risk factors in the family. And then if she does qualify based on her medical background and her family medical background, we'll begin to do medical tests on her. And these tests will determine if she has a normal number of eggs, a high number of eggs for her age, or a low number of eggs. And we'll do a genetic test to determine if she's a carrier for any rare genetic diseases, such as cystic fibrosis. We'll also do infectious disease tests to screen for infection risk. And the egg donor is screened by a psychologist who will interview her, and also the egg donor will complete a psychological test. It's a computer-graded multiple choice test to assess her psychological health. And finally, the donor has a drug screen to determine if she's taking any illicit drugs.
And so once the egg donor is obviously one part of the combination that ends up in a surrogacy journey. What about what are the other elements, and how do they undergo a similar process to the egg donor, so the sperm donor?
Yes, the man who's providing the sperm, if it's the intended father, he will also have tests such as a semen analysis, a sperm test. He'll undergo infectious disease testing. He will also complete information about his family medical background for the genetic counselor to be able to give him advice regarding the potential selection of the donor. And he'll have a blood test or a saliva test to determine if he's a carrier for 175 or more rare genetic diseases, because we want the man and the woman, the man providing the sperm and the woman providing the egg, to not carry a mutation that could lead to a child with a rare genetic disease. Mm-hmm. So by testing both parties, we can determine that. Now, if the future parents are using sperm from a sperm bank, we'll look and see what testing the sperm bank did on genetic screening to make sure that it's appropriate and up to the standards that the egg provider will be screened for.
Okay. So as intended parents, there's a desire, obviously, to get pregnant on the first transfer, and that's I think most people's wish. What do you do at ORM to sort of maximise the chances of that?
Well, I think if the intended parents are using an egg donor, it's important that the egg donor be carefully screened to make sure that her egg quality and egg numbers are appropriate. If the intended parents are using the future mother's own eggs, testing will be done to determine how she might respond to fertility drugs to come up with an appropriate medication protocol for her and her treatment in the United States if she's coming to the U.S. for care. Certainly, there are a variety of factors that can influence the chance of a live birth through an embryo transfer associated with surrogacy, and that can include factors involving the eggs and the sperm. As it turns out, it's really the egg factor or the egg quality that has a higher chance of influencing the outcome of IVF than the man's sperm. There are ways of trying to develop embryos that are of optimal quality. This includes growing the embryos in the laboratory until they're 5 or 6 days old, because embryos that are more advanced in development have a grading that's given to them that would predict their potential success rate based on the quality of the microscopic appearance of the embryos. It's also become very common in our clinic, as well as in other clinics in the United States and in North America, to do genetic testing on embryos, where we can remove a small number of cells from the future placenta without it damaging the embryo. And the genetics lab then can determine if the cells that have been biopsied have the correct number of chromosomes, which is 46 chromosomes, or an abnormal number of chromosomes. And actually, for many people, this is quite surprising. The rate of genetically abnormal embryos is relatively high in the early stage of development. Of course, through the screening process, when we biopsy embryos, we may be identifying embryos that would never implant or would lead to a miscarriage. So screening the embryos isn't always necessary by any means for intended parents to have a healthy baby, but it may increase the efficiency of the process and result in fewer embryo transfers for the surrogate, especially if the surrogate is having only one embryo transferred at a time.
Okay, thank you. You mentioned earlier on sort of advances in fertility medicine that you'd seen. What does the future hold? What is the next big thing for fertility medicine?
I think that there will be continued refinements in our ability to assess the health of embryos in the laboratory. This may be through genetic tests that are done on the embryos, not through biopsying the cells, but through analyzing degraded DNA that may be present in the culture medium, the liquid that the embryos grow in. There's certainly interesting work in this regard. There also are ways that are being developed to try to identify the growth rate of embryos in the laboratory and determining whether different appearances of the embryo, different stages of growth, may correlate with the ability of the embryo to attach and grow into a baby. There's also some tests that are becoming more readily available to analyze the uterus of the woman carrying the pregnancy. I think in the future we may be doing more biopsies of the uterine lining of the future surrogate to make sure that the health of the lining is ideal. For most surrogates, the health of the lining is ideal just because they're women who've had healthy babies in the past. But unfortunately, there's not 100% implantation and live birth rate. So fertility physicians and scientists are always looking at ways to try to improve outcomes to help our patients.
So we'll, thinking about the future, we'll be seeing you at our event in London in a few weeks' time. So we're looking forward to that. Thank you very much for taking the time to talk to us today. And we'll obviously make sure that the ORM social media is there as well if people want to get in touch. But Dr. Hesla, thank you very much.
Thank you. It's been my pleasure.